Hello everyone, today we're going to talk about opioids and realize that I'm just talking about one part and Dr. Mollenkopf's going to talk about another part. We have one more module after this with me. I'm sure you're excited, so let's get ready. We're going to talk about opioids, moderate opioids, miscellaneous pain medications, so drugs that treat migraines and gout. In looking at pain use in general for opioids, some of this is review. Pain assessment is something you're going to do every single day, and there's multiple scales Dr. Kazanchik went over with you. In terms of dosage determination, yes, the prescriber comes up with the dosage determination, but if the patient's pain is intolerable, you're going to have input into that. And we're going to talk about there are some cases where you actually titrate the dose, and that's the Passero pain scale for IV opioids. So we'll talk about a specific case in that regards. Dosing schedule. It's really important that if someone's in pain that they get pain medication on a regular schedule. That should make sense, right? However, it doesn't always happen that way. Avoiding withdrawal. As per your book, anytime someone's on continuous pain medication for 20 days or more, physical dependence can develop. In this case, you need to be thinking in the back of your mind, if this is possible, we should suggest tapering pain medication for individuals like this. And someone who's been on pain medication for a very long time, and perhaps with high doses, slowly tapering them off of that medication can be tricky, and it involves the whole team. I'm going to talk a little bit about PCA in a minute. And last but not least, I want to mention, and I'm sure Dr. Mollenkopf's going to talk more about this, REMS strategy. So REMS stands for Risk Evaluation Mitigation Strategy. Due to the multiple amounts of opioid deaths in the past 10 years, the government stepped in and they realized that patients and prescribers need a better way of prescribing and taking pain medication. This program is voluntary in nature. PCA stands for patient-controlled analgesia. I'm sure some of this is review for you related to foundations. However, it's worth going over. So here's an example of a pump. PCA should always be controlled by the patient, not by the family, but not by the nurse. The maintenance rate, you may or may not have one. So that's a basic baseline rate of pain medication. On top of that, patients will get the ability to have a bolus. So perhaps they have breakthrough pain. In this case, they would get a bolus. So the patient would press the pain button and they would get a bolus as prescribed by the prescriber or the pain team. Now, just because you have the ability to bolus does not mean you can continue to press that button, keep adding on. There's such a thing as called the lockout. The lockout is usually a amount of time set by the pain team or the prescriber, and that prevents someone from constantly clicking the pain button. Sometimes pressing the pain button inadvertent by the patient, but sometimes it's not. Okay, let's get right into the opioid analgesics. The gold standard happens to be morphine. Morphine acts in the CNS by stimulating mu opioid receptors. Receptors are in more than just the CNS, they're throughout the body. Particularly, we have mu receptors in the GI tract. Therapeutic use of morphine is for moderate to severe pain, cough suppression, and suppression bowel motility. There's some GI instances where we want to slow down motility, and it can be used to sedate a client. Pharmacokinetically, the onset's slower with oral morphine versus parenteral. That should make sense. It comes in different forms: oral, IM, IV, sub-Q, epidural, intrathecal. Duration differs. You have immediate release versus extended release. There is a large first pass mechanism with morphine, and pain relief occurs once it passes the blood-brain barrier. So If it has poor lipid solubility, it's going to take a little while. It's renally excreted, and the metabolites, once metabolized by the liver, metabolites can cause analgesia as well, and hence also cause adverse effects. In looking at morphine, adverse effects are going to be similar across all opioids themselves. The big one that we worry about all opioids happens to be respiratory depression. So clinically, what that means is a respiratory rate less than 10 and SATs less than 93%. They can also have constipation. We have mu receptors in the gut cause constipation. Morphine is can cause vasodilation, so it can cause hypertension itself. In addition, it can cause nausea, dizziness, and vomiting. It naturally causes itching. A lot of patients think that the itching is an allergic reaction when really it's not. It's just part of the drug. It has the ability of suppressing cough. This is good as a therapeutic use, but it can be bad postoperatively because it suppresses the cough suppression and someone adequately ventilating their lungs, making them more at risk for pneumonia. It can cause sedation. Sedation can lead to respiratory depression, meiosis. Urinary retention is particularly bad for those that might have BPH, or benign prostatic hypertrophy. Principally, though, it can cause tolerance, dependence, and abuse. So morphine, after a while, body builds up a tolerance and needs more morphine to do its intended effect. Morphine can also cause dependence. So if someone's dependent on morphine and they stop taking it, they will go into withdrawal. Toxicity or overdosing morphine, you can go into coma, have respiratory depression, pinpoint pupils. In looking at drug-drug interactions, anything that can cause increased respiratory depression we have to watch. So any other CNS depressants, so that's benzodiazepines, alcohol, any other anesthetics, antihistamines, all can cause respiratory depression. And adding morphine onto it is a cocktail that can be fatal. Knowing that morphine can vasodilate, other hypertensive agents can cause more of a decreased blood pressure. Anticholinergics can increase constipation and urinary retention, already caused by morphine. Nursing implications. One thing I will review with you later is the pain sedation scale. This is for IV opioids only, okay? We always monitor vital signs, respiratory rate, blood pressure, O2 sats. And you want to look for drug-drug interactions, as I mentioned before. And you only want to allow the patient to use the PCA, not the family member. And most importantly, monitor the pain response. Is it effective? Is it not effective? In looking at morphine, there are some drugs that have names very similar to them. Hydromorphone or Dilaudid has a drug name very similar to morphine, and their efficacies are not the same. 1 milligram of hydromorphone is worth 7 milligrams of morphine. So hydromorphone is more potent than morphine. It's really important. I mentioned we go over the Passero pain scale. This is just a quick highlight, but the basic principles are the following. We start with the lowest possible dose, IV dose of an IV opioid, and titrate up. We monitor pain and their sedation level and respiratory level if you're astute after 10 minutes. We hold any pain medicine for sedation or unresponsiveness. And we will practice this a little bit later. So the next drug we're going to talk about is fentanyl. It is method of action, same as morphine, except for it's way more potent. It's synthetic. It can be given many different ways, IV, transmucosal, transdermal, epidural, many different ways. Same adverse effects as morphine, especially respiratory depression. Hence, we have a lot of deaths related to fentanyl. due to respiratory depression. One unique thing is that you can have respiratory depression even after you remove a patch. So that's one thing to keep in mind. Fentanyl levels can be increased with other things. There are CYP3A4 inhibitors like ritonavir. So ketanazole is another good example. So they can be increased with other inhibitors. As a nurse, we want to monitor for adverse effects. So the big ones are respiratory depression, but we also talked about other things like constipation. And patch use is a big deal with fentanyl. Let's review that. So with the patch, the onset of pain relief is slow, and the peak isn't really seen for about 24 hours, but you can use a short-acting pain reliever for breakthrough pain until the patch is working. Even after the patch is removed, it can continue to work for 17 hours after it's removed. The patch should be removed every 3 days and should be disposed of appropriately so kids cannot get them. If someone has a fever, you can have increased absorption up to 15%. And the patch really should not be used for those under the age of 2 or less than 110 pounds. So the next drug we're going to talk about is going to be methadone. Method of action is very similar to morphine. It affects the mu receptors. This is used to treat addiction, however, and Dr. Molenkoff's going to go over it. The nice thing about methadone, it's formulated so you only have to take it once a day, which makes it ideal for a methadone clinic. Before patients go on methadone therapy, they usually check their cardiac history. They'll do a 12-lead EKG, and we monitor their QT interval periodically. Like other opioids, it can cause respiratory depression, and use with other CNS depressants can be lethal, so taking alcohol while on this can be lethal. If a patient's taking other drugs that inhibit CYP3A4, it can increase the drug levels of methadone. So I gave some examples with fentanyl, but same thing here. And other drugs that prolong QT interval can further prolong QT interval if also taking methadone. Erythromycin is a good example of this. Quinidine as well. Patients need to know how to take it as directed, and they should know about drug-drug interactions, and they should know about what's it like if they have drug toxicity, respiratory depression, and what to do in terms of an overdose. So let's talk about Demerol. It has a method of action similar to morphine. It's very lipid soluble, which makes it really, really nice. Bad thing is that the metabolite meperidine, or Demerol, accumulates quickly and can cause some bad effects. And in fact, this metabolite is toxic to the body and can cause seizures, and especially with those that have renal dysfunction, so those that can't excrete the metabolite in the drug, this can happen rather quickly. So that's why we don't use it a whole lot anymore. It also can interact with other MAO inhibitors and cause serotonin syndrome. We do use it in a few instances, post-surgical rigors, amphotericin B-induced rigors. You might see in OB, or you might see it when a patient has drug allergies to all other opioids. You may see this, but it's considered kind of dangerous. So let's look at the moderate opioids. Your book classifies these as moderate. Codeine. Codeine is an agonist in mu receptor. The interesting thing is it's a prodrug to morphine. So it has to be converted. Therapeutically, we use it for pain relief, cough suppressant. It does produce sedation, analgesia, and euphoria. But because it has to be metabolized, not everybody has the ability to convert codeine to morphine. fact, almost 10% don't have this enzyme. So that leaves some variability between people that get no effect from the drug or a lot of effect from the drug. Hence, we try not to use it anymore. But you will still see it. It can be formulated alone or with aspirin or acetaminophen. It comes in tablets or a syrup. So adverse effects with codeine: it can cause respiratory depression, less than morphine, urinary retention, constipation, cough suppression. We watch for drug-drug interactions with other drugs that cause CNS depression. That's assuming that it's effective in that client. And nursing implications: it can cause abuse potential. We monitor for vital signs and look for drug interactions. This drug can be reversed by naloxone. But the big thing, no matter what, is that effectiveness of this drug is comparable to the effectiveness of Tylenol or aspirin alone. That's what APAP stands for, or ASA, aspirin. So it's really not that more effective than Tylenol that doesn't have all these bad adverse effects. So we really try and avoid codeine in healthcare. The next drug I'm going to talk about is oxycodone. Oxycodone, again, is an agonist of the mu receptor. It's used in pain. You can find it with other combination products like with aspirin and with acetaminophen. It comes in extended release and immediate release. This is interesting because there's a lot of abuse potential with oxycodone. Okay, the old formulations that had OC on the tablets could be crushed and snorted, or they could be injected when they're combined with water. So the new tablets now have OP on them, and if they're crushed and snorted, it will burn your nasal passages. And as per the book, if reconstituted, it forms a gel, so it can't be injected. Adverse effects are similar to morphine. Same as before. Respiratory depression, although less than morphine itself, urinary retention, constipation, cough suppression, and meiosis. So nursing implications, well, we watch for adverse effects, abuse potential. We look for, warn patients about drug-drug interactions with other CNS depressants. This is a pretty big deal. This drug can be reversed by naloxone, and tolerance and physical dependence can occur with this drug as well. Okay, so so far all the drugs are very similar in terms of adverse effects. This one is quite unique. Pentosazine, or Talwin, it is an agonist of the kappa receptors and antagonist of the mu receptor. So at the kappa receptors, you can have analgesia and sedation, okay, and respiratory depression, but there's no euphoria with this drug, okay. They use it to mild to moderate pain, and it should never be given to anyone who's physically dependent on an opioid agonist, right? Because if they're dependent on an opioid agonist, this will antagonize them, and it'll throw them into withdrawal. All right, so if you were to look at the drugs that all of these are very, very sensitive drugs, right? But there are some drugs we just generally try to avoid. Meperidine. We avoid meperidine because, remember, due to renal excretion, you can have the toxic metabolites build up, and it can lead to confusion and seizures, for instance. Codeine we avoid because almost a tenth of the population can't metabolize it. Therefore, it's not effective, or it's super effective. So effectiveness is variable, and that's a little scary. And then pitocin, remember, it's an agonist of the kappa receptors and an antagonist of the mu receptors. If someone's dependent on an opioid, this drug can throw them into withdrawal. So these are basic agents we try to avoid. In summary, in looking at pain, in terms of the opioids, assessing pain is vital. Looking at the risk that clients bring in. So anybody who has respiratory depression already, anyone with COPD, asthma, an opioid can further compound this issue, right? Cardiovascular issues. So remember, if someone's hypertensive, morphine can cause more vasodilation and more hypotension. CNS issues. So we watch very closely. Anybody who has increased intracranial pressure, you don't want to give them something that's going to cause vasodilation. It can increase their intracranial pressure. Or if we give it, we monitor it very closely. We do know that anything that causes CNS depression, when added to an opioid, can further compound CNS depression and can be lethal. The route matters. For instance, IV fentanyl, onset's nearly immediate, but with a patch, the onset's very slow. We need to reassess anyone who's on pain medication, especially opioids, because reassessing them, one, we want to make sure their pain disappears or becomes more tolerable, and two, they're not suffering from respiratory depression. We monitor other things like labs, special renal and liver function in older patients and neonates. Let me rephrase that. Older patients and neonates will most generally require smaller doses because they can't easily excrete these substances. Let's look at miscellaneous pain medications now. So looking at gout pain, if we're looking at acute gouty arthritis, we're looking at colchicine. Now, colchicine used to be the drug of choice for acute gout attacks, but it's now NSAIDs. But this drug's only used for gout. Adverse effects. And let me get into a little bit what gout is. It's a recurrent inflammatory disorder. So again, inflammation characterized by hyperuricemia and joint pain, especially in the large toe. So you can read more about this in chapter 74, but this used to be, remember, the drug of choice for acute gout is now NSAIDs. Adverse effects, GI distress. It can cause bone marrow suppression and rhabdomyolysis. We use it very cautiously in the elderly and those with renal dysfunction, and it interacts with those that also are taking CYP3A4 inhibitors. You can take this with food to minimize GI distress, and you really should talk to patients about gout prevention. So one good way is decreasing things that might increase your uric acid. So that's foods high in purine, red meat, scallops, for instance. They should really take a good water intake and exercise appropriately. Allopurinol is generally for chronic gout. So this is a xanthine oxidase inhibitor. So it inhibits uric acid production. So you can use this for hyperuricemia due to gout or cancer. Adverse effects, you can have a hypersensitivity reaction to allopurinol. You can have acute kidney toxicity or hepatitis, and you can also have GI distress. So the next group we're going to talk about pain that is caused by migraines. We know that migraine headaches are generally a neurovascular disorder that involves dilation, inflammation of the intracranial vessels. Okay, this can lead to pain, and perhaps other symptoms that the patient might experience might be dizziness, and they can be quite severe for a lot of patients. So we can take some drugs that can help abort migraine attacks. So the ones we're going to talk about are triptans and the ergots. So we're going to talk about sumatriptan and ergotamine. The first drug we're going to talk about is sumatriptan. So sumatriptan is a serotonin receptor agonist. If you remember what serotonin does, serotonin actually contributes to vasoconstriction. So this would be very useful for someone who might have a migraine, right? To have some vasoconstriction, decrease the pressure on the brain. Therapeutically, it's used to abort acute migraines. It's the drug of choice here. It's pretty well tolerated, but because it can cause some vasoconstriction, it can also cause angina or chest pressure, dizziness, and it's teratogenic as well. So that's not necessarily good. So we really don't want to give this drug to anyone who might be at risk for coronary artery disease or has uncontrolled hypertension, because it can make those conditions worse. It does have drug-drug interactions with other things that can increase serotonin levels, so MAO inhibitors, SSRIs, and we don't want to give it within 24 hours of ergotamine, which I'm going to explain in a minute. And we need to educate patients when to take sumatriptan. So we want to take at the onset of symptoms. We want to avoid any sort of triggers that are related to the migraine. And if women or individuals are at a point where they are at childbearing risk, they need to know that they need to be cautious in terms of pregnancy if they're going to be taking this drug. Ergotamine is the other drug that can be used for migraine pain. You'll see this a lot in NCLEX for whatever reason, but it's an ergot alkaloid. It promotes vasoconstriction in the cranial arteries. It's considered second line for migraines. It can be given in a multitude of ways, orally, sublingually, or rectally. It can cause physical dependence, and it also triggers the chemotherapeutic zone, causing nausea in about 10% of the patients. Other adverse effects can cause weakness in the legs, myalgia, numbness, tingling in the fingers. You can have angina-like pain, tachycardia, or bradycardia. Individual variation. Anyone who has hepatic or renal impairment or sepsis, ergotamine can make worse, because remember, it will decrease blood flow to those organs. Also true with peripheral vascular disease, coronary artery disease, and its pregnancy category X. So with ergotamine, it should be separated at least by 24 hours with anyone who's also taking a triptan. Because if you take it too close together, so if you take sumatriptan and then start ergotamine the very next day, you can actually you can cause vasospasm. Anybody who's also taking inhibitors of CYP3A4, it can also increase vasospasm. So there's the same drugs, ritonavir, erythromycin, itraconazole, or other less potent inhibitors of CYP3A4 like grapefruit juice can also cause vasospasm. So we want to be watching for those drug-drug interactions. Additionally, nursing implications. If they have nausea, because nausea is actually one sign of a migraine, a severe migraine, right? Increased intracranial pressure can be characterized by acute nausea. We want to make sure that it's just nausea related to the drug. So they might give another drug to decrease the nausea, like metoclopramide is recommended by the book, and you might recommend that to the prescriber. We do know that dependence actually happens with this drug, so patients should be on this drug for a low dose as possible for as short a time as possible. And withdrawal from this drug can actually mimic a migraine. So patients will present with a headache, nausea, vomiting, and maybe restlessness. So knowing that perhaps if someone appears with those symptoms, it may either be a migraine or it might be withdrawal related to this drug. So in ending, pain is a very complex topic. It's what the patient says it is. As a nurse, our job is to listen to what the patient says is their pain. If they're prescribed something for pain, we need to monitor the patient very closely. And based on the route, you might monitor them even closer. So if it's IV or epidural, monitor them very closely. Drugs that affect the COX system, the adverse effects are very different than adverse effects with opioids. And pain related to gout and migraines is also a very different thing. So knowing the source of the pain, what's being given for pain, our job as a nurse is to make sure that the pain is being treated and the adverse effects are being minimized. So with that, have a great day.